Thank you very much, Paul. Thank you very much, Rob, and the CCR Organizing Committee for this wonderful opportunity to present the 65 trial. I'm definitely very excited to be here. This trial was funded, as you know, by the NIHR Health Technology Assessment Program, and we're grateful for that, definitely. We're also very grateful that the results of the trial have been very recently accepted for publication in JAMA. And so on behalf of the entire 65 team, we'd like to extend our thanks to Drs. Angus Bauschner and the JAMA editorial team. I'll be presenting today on behalf of the trial chief investigator, Paul Mounsey, as well as this illustrious group of individuals who compose the trial management group and trial steering committee. If I may, I'd like to start by providing a little bit of context and explain why we felt it was important to conduct this study. In a nutshell, the short answer to that question is that vasoactive substances became an integral component of routine care for shock and hypotension at a time when perhaps new medications weren't under the same scrutiny as they are today before becoming available for clinical use. And I guess one way of putting it is that we felt that the careful evaluation of the risks and benefits associated with these potent drugs was long overdue. The other reason is that if you think about it, when our daily use of vasopressors hinges on a number of assumptions that may be flawed. We tend to use these drugs to treat distributive shock because we worry that excessive vasodilatation causes low blood pressure and that low blood pressure causes malperfusion. But if you think of it, these distributive shock states are associated with high cardiac outputs, and it's unclear that blood flow to important organs is actually that low. And if it is indeed the case that blood flow is reduced, increasing vasoconstriction may not be the way to increase perfusion. If anything, this may actually reduce blood flow to organs. So we thought it was an important area of research to tackle, but to study this well, you need clinical trials. Relying on observational data to study this, you end up with unremediable residual bias. And it just so happened that very few patients had been randomized in clinical trials up until this point in time. Most of them were enrolled in the sepsis-PAM trial that you know well, which randomized patients with septic shock to either a higher or a lower MAP target and the corresponding higher or lower vasopressor doses. The other trial on the left is the OVATION trial, a much smaller feasibility pilot study conducted in Canada, which resembled in many ways the sepsis-PAM trial, except that eligibility wasn't confined to septic shock and that the blood pressure targets were lower. In both of these studies, interestingly, the mortality was higher in the higher MAP target arms, but the difference was not statistically significant, and the interpretation of the results went in different directions. Later on, when we pooled the individual patient data from both studies in this individual patient data meta-analysis, we found that again, the mortality in the higher MAP arm was higher, but perhaps more interestingly, we observed that this higher mortality in the higher MAP target arm was perhaps more pronounced in patients who were older. And so that led to the hypothesis, we derived from this observation, the hypothesis that perhaps vasopressors, defined as any medication that induces vasoconstriction, may be overall non-beneficial, but in fact harmful in older patients due to their more limited physiological reserve. And so the 65 trial asks whether reducing exposure to vasopressors via permissive hypotension reduces 90-day mortality in patients 65 years old or older who are receiving vasopressors for vasodilatory hypotension. This was an investigator-initiated, very pragmatic, unblinded trial. And lest you forget why we called it that way, it was conducted across 65 sites participating in the case mix program in the UK. We enrolled patients who were 65 years or older, who were receiving vasopressors for vasodilatory hypotension, as long as the vasopressors had been started within 6 hours of randomization, and as long as the treating physician acknowledged that adequate fluid resuscitation had been completed or initiated, and that vasopressor therapy was going to continue for at least 6 hours. We excluded patients who were hypotensive for other reasons, as well as patients receiving vasopressors for brain injury or spinal cord injury, and patients whose death was perceived as imminent or who had previously been enrolled in the trial. Patients randomized to the permissive hypotension arm received vasopressors titrated to a MAP target of 60 to 65 millimeters of mercury, and those randomized to the usual care arm received vasopressors according to usual care. The allocated interventions were administered throughout the ICU stay, and all other therapies were at the discretion of the treating teams. As I said, vasopressors in this trial were defined as any drug inducing vasoconstriction, and we explicitly distinguished vasopressors from pure inotropes, such as milrinone and dobutamine, which were not affected by the study protocol and could be used freely in both arms. Randomization was available 24/7. It was stratified by site using permuted blocks of variable length. We, in this context of resuscitation for shock, we used a deferred consent model, and patients lacking the capacity to consent at randomization were approached later on by the research teams when deemed appropriate. Posters and leaflets were available, and data were retained up to the point of withdrawal of consent. The primary outcome was 90-day mortality. We also evaluated ICU and hospital mortality, length of stay in the ICU and hospital, duration of respiratory and renal support, number of days alive and free of respiratory and renal support up to day 28, as well as cognitive decline measured by the IQ code score at 90 days and at 1 year, and health-related quality of life also at 90 days and at 1 year. A sample size of 2,600 patients provides a 90% power to detect a 6% absolute risk reduction from 35% in the usual care arm, as estimated from the case mix program data, to 29% in the permissive hypotension arm, assuming a 2.5% loss to follow-up. The Data Monitoring and Ethics Committee, composed of Professors John Norrie, Andreas Lopakis, and Danny McCauley, reviewed the single interim analysis, which included data from 500 patients, and recommended that we continue without modification. The study protocol, the analysis plan were both fully published, and the trial was duly registered. Now the results. The 65 teams screened for enrollment 10,755 patients, and of those, 2,930 were deemed eligible. And of those, 2,600 were randomized. So this amounts to 89% of all eligible patients actually randomized in this trial. Of the 2,600 patients, 2 were randomized in duplicates, 137 withdrew or refused consent, and only 1 was lost to follow-up. So at the end of this, 2,463 patients were included in the primary analysis, or 95% of all patients randomized. At baseline, the two groups were well balanced in terms of age, sex, chronic comorbidities. The one exception perhaps being the proportion of patients able to live without any assistance for daily activities. There were 65.6% in the permissive hypotension arm and 69.1% in the usual care arm. Other than that, the illness severity scores at baseline, the proportion of patients with sepsis, septic shock, or without sepsis were the same. The map at randomization was also very, very close, as was the intensity of vasopressor therapy and the duration of vasopressor therapy before randomization. So, but if the two groups were quite similar at baseline, immediately after randomization, they diverged significantly in terms of exposure to vasopressors. Vasopressors were discontinued earlier in the permissive hypotension arm, on average 10 hours earlier than in the usual care arm. The trial did not impact the selection of vasopressor agent, but it did change the total dose of vasopressors administered to patients and calculated in terms of norepinephrine equivalents. The total dose was 31.5% in the permissive hypotension arm and 31.5 milligrams in the permissive hypotension arm and 44.3 milligrams in the usual care arm. And not surprisingly, the average MAPS while receiving vasopressors was also lower in the permissive hypotension arm. Remember, those averages were calculated strictly from hourly MAP values collected while patients were receiving vasopressors, and the vasopressors were stopped earlier in the intervention arm. The co-interventions were used rather similarly in both arms. There might have been slightly more corticosteroids used in the usual care arm. Other than that, pure inotropes and fluids, interestingly, were seen to be used equally in both arms. The fluid balance as well as the urine output was not different between the two arms, and this was calculated during the first episode of vasopressor therapy. Now, the primary outcome of 90-day mortality. We found that in the permissive hypotension arm, 41% of the patients had died by day 90, and in the usual care arm, 43.8% for a difference of 2.85%, 95% confidence interval ranging from minus 6.75 to plus 1.05%, and a corresponding p-value of 0.15. The pre-specified adjusted analysis for the independent variables appearing at the bottom of the slide yielded an odds ratio of 0.82 and a 95% confidence interval ranging from 0.68 to 0.98. And you can appreciate that in a post-hoc analysis, when we measured relative risk, the direction and general trend was the same, but the 95% confidence interval crossed the no effect line. On screen, you can see the survival curves. They diverged fairly early on, about 1 month after randomization, and never crossed thereafter. But the difference in time to death was not statistically significant, as you can see examining the hazard ratios at the top right corner of the screen. We ascertained whether the treatment effect varied across different subgroups defined by 7 subgroup defining variables. And the test for interaction between treatment effect and chronic heart failure, atherosclerotic disease, predicted risk of death at baseline, sepsis categories, and the intensity of vasopressor therapy was not statistically significant. The interaction between the intervention and age, again, was not statistically significant, but we found that the reduction in mortality associated with permissive hypotension was more pronounced in patients who had been identified at baseline as being chronically hypertensive. This analysis was not corrected for multiple testing, however, and should be interpreted with caution. These are the secondary endpoints. We found that permissive hypotension did not impact the duration of advanced respiratory support, and it also did not change the number of days alive and free of respiratory support by 28 days. Similarly, it did not change the duration of renal replacement therapy or the number of days alive and free of renal replacement therapy by 28 days. Cognitive decline at 90 days and at 1 year, assessed by the IQ code score, which is a score that ranges from 1, signifying much improved cognitive function, to 5, signifying much worse cognitive function, was also not different between the two arms. A value of 3 means no change. And health-related quality of life also was not different at 90 days or at 1 year. We paid special attention to adverse events in this trial. There were a total of 79 serious adverse events reported in the permissive hypotension arm and 75 in the usual care arm. You can see those SAEs broken down in different types of SAEs that we had either pre-specified on the left side of the screen or that were reported throughout the course of the trial. So in summary, we found that permissive hypotension was associated with a significant reduction in exposure to vasopressors, but was not associated with a statistically significant reduction in mortality, and was not associated with a difference in secondary outcomes or adverse events. I'd like to take the last few seconds of this presentation to wholeheartedly thank the wonderful clinical and research teams at each of the 65 sites, as well as the patients and the families for accepting to participate to this trial. And perhaps on a more personal note, I feel I'm a very privileged individual as a Canadian critical care trials group member. I have the opportunity to work with some of the most brilliant researchers in this area, but for this specific trial, the full might of the NHS, NIHR research infrastructure and the expertise of the wonderful ICNARC CTU was needed, both of which we'd be happy to import along with Harry and Megan, by the way. But on a very personal note, Paul, Kathy, and Alan, I'll be forever grateful for the exchange of ideas and the friendship. Thank you.
Fantastic. Thank you, Francois. So there we have it. So time for discussion. Anders Perner from Copenhagen. Editorial, please. Thank you.
Thanks, Paul. Slides, please. Good morning. Thanks, Rob and team, for the invite and to host this 65 trial presentation. I think it's an amazing day for all of us. So I was kindly invited to give this editorial. I'll mainly touch upon the interpretation of the trial, which I believe that I and we in general can do more freely than the investigators' presentation that you just saw. Oh dear. This is very jumpy. In between there was some kind of a joke with being age 65. Just to remember me to hugely congratulate the investigators, the ICNARC group, Kathy, Paul, Francois, David, all 65 investigators, and I think the full UK critical care community for producing this very important result for us in a meaningful way, I think, and I think we will, as I'll show, learn a lot and potentially improve the care of our patients. So, you saw this as the sort of overall conclusion of the trial. conservative as the investigators should be, interpreted sort of in the present paradigm where we sought to use this term, statistical significance, to sort of dichotomize trial results. That's the part that I will challenge. I hope I can get this to work. You did it much better than me. Yeah, but it turns double. Now it doesn't turn at all. So this has been discussed when the primary outcome sort of fails, which is a bit harsh word, I think. A series of papers in the New England Journal of Medicine. This specific one asking the question, what to do next when you have a so-called failure? And there's a table in that paper listing questions to ask. Some of them apply for the 65 trial, some does not, and I think there are some important ones that are not on this list, and I'll touch upon those. I think this is a very important paper that came out last year. 3 statistical colleagues of ours, 800 co-signers on this paper, named scientists rise again. And this is the term statistical significance. The main point of this paper is that we should stop dichotomizing trial results. It's too simplistic. These are the results you just saw. And this is obviously the main result, 3% mortality difference between the 2 groups. I would say personally that I think this is an important difference. Others have thought so as well. The ANSIC-CTG in some of their early trials, the SAFE study, defined the sample size based on this minimally important mortality difference. So I think myself and many others would consider this difference important. So the challenge is this. So the p-value was 0.15. Again, by the current definition, this result is not statistically significant. But what does it mean? I'm not a statistician, but I'm quite sure it does not mean that we have proven the null hypothesis. Clearly, the confidence interval gives more information and is more and more used to report trial results in general, also here. So the confidence interval goes from a quite large difference, -7, favoring permissive hypotension, and potentially 1% mortality increase with the use of the intervention. Again, in the sort of current paradigm, we'll dichotomize this and say, well, the null is included in this range, and therefore the result is not statistically significant. So these are the point estimates that are sort of compatible with the trial results. And by dichotomizing at null, we will make these numbers equal, that a +1 is equally as likely as -3, for instance, but they are not. -3 in this data set is the most likely result. And the further you get away out into the 95% confidence interval, the less likely are the results. So 0 and +1 is less likely than -3. But we, in the current paradigm, with dichotomizing, we create these numbers as equal. They are not. So I think this leaves us in a position where we should change where to go, both with the results of this trial, but also in general in how we interpret trial results. There are obviously many more issues to consider than the simple statistics of the trial. Did the trial result come out of a trial with high internal and high external validity? I think yes, for the 65 trial. That's important. Was the primary estimate, the -3, supported by sensitivity analysis, subgroup analysis, secondary outcomes reported? They were. So there were a number of missing variables for the primary outcome as prudent, worst case, best case scenario analysis were done, and they supported the primary result. There was a adjusted analysis for potential baseline imbalance. Again, it supported the primary result. You already saw this, a number of subgroup analysis. All point estimates here favor permissive hypotension, except maybe patients with no sepsis, maybe. But the vast majority favors the intervention. So again, supporting the primary result. Importantly, as you saw, one of the secondary outcome measures were time to death at 1 year. The lines do not cross, so this result again supports the primary result. So we can mark those important considerations as well for the 65 trial. Is it plausible? Is it plausible that the use of the intervention reduces mortality by 3% absolute? I think it is. The trial was powered to show a 6% reduction, so this is half. Another mark for the 65 trial. I think there is a case for interventions where it means that we do less. I think if you want to do more, there's a higher burden of proof on the shoulders for those who want to do more. In this case, reducing the exposure to vasopressor, we are doing less. So I think the 65 trial marks this as well. We will do less if we incorporate the intervention into clinical practice. Finally, no trial result can stand on its own. Therefore, it should be incorporated into updated meta-analysis, preferably of trials with low risk of bias. And obviously, this has not been done yet. Results are presented here for the first time. I'm quite sure that I would be very surprised if the investigators are not working on an IPDMA, so an updated meta-analysis. And then we can update guidelines. And all these processes are extremely important for, obviously, clinical decision-making. Oh dear. What's that? Waiting. Loading. All right. So, to sum this up, so I think this trial posed a highly relevant clinical question. I think the hypothesis behind was supported by good clinical data. I think the investigators are to be congratulated to perform a large, lower risk of bias trial. I think the results, as I show, is very useful. They come with some uncertainty. This is clinical research for you. It will likely change my practice. As I said, I'll probably wait for the updated systematic review to make the final decision, and maybe even updated clinical guidelines, at least our local ones. But until then, I'll say huge congratulations. I'm sure that this trial result will live for a long time, both in itself, in updated systematic reviews, in guidelines. And again, I think we should congratulate the investigators, the full community, the UK Critical Care Research Forum, for this work. It points to a bright future for critical care research in general and in the UK in particular. Thank you.
Thank you, Anders. Cheers. Anders, thank you very much for that very insightful editorial. I mean, we've time. Are there any points that the investigators would like to take on from Anders at the moment, or are you happy if we move on to questions? Any particular points you'd like to raise at this point?
I'm quite happy by the interpretation of the results we just heard.
Yeah, okay. So we'll move on to questions. I'd like to focus initially for the next sort of 10 or 15 minutes on the outcome of this trial. We're going to move on to the implications of this trial in terms of performing research in critical care. Paul's going to talk to that point later on. So if there are any questions on that, we might park them. Just a quick straw poll. I'm on call this weekend. We contributed to this trial. And I mean, I'm a bit more impatient than Anders, and I might not wait for the meta-analysis. So who's keen on introducing permissive hypotension right now in patients of 65 and over? Could you vote, please? Because my trainees are going to find out this fate. Okay, who wouldn't and wait for a meta-analysis? Okay, thank you very much. That's very helpful to my practice this weekend. Thank you. So congratulations. Practice changing. I guess one of the generalizability questions and that I was considering about applying this in my own practice was obviously there are different causes of hypotension within the intensive care unit that I might be looking at sedative practice, the use of regional blockades, or indeed the cause of hypotension in the first place. Now, you've done a big trial here, and I'm guessing you're relying a little bit on the randomization process, but did you record any data in a trial that you were trying to record as little data as possible that might help me with that question?
Well, we carefully ascertained whether patients. Do you want me to?
Yeah, please. Yeah.
We carefully ascertained if patients met sepsis criteria as shown, and did not find that that significantly modified the treatment effect. And we also meant to include patients whom the physicians believed to be, experiencing vasodilatory hypotension, and not specifically sepsis, because the underlying hypothesis wasn't getting at a specific effect of a specific drug for a specific illness, but rather the risk profile of a class of medication in a population that had been enriched as perhaps being more prone to adverse effects. So other than identifying sepsis and categorizing sepsis into sepsis and septic shock, we haven't got the data to date to go into more specifics, I guess. But perhaps in the future with second.
But yes.
And to say that this was an efficiently designed trial where we tried to nest within the case program. So we've done a full linkage of all the patients within the case program, which is the national audit for critical care units in the UK. So if there's some post hoc insights, we will certainly be trying to make the full use of the data we've both collected and we've got available through routine linkages to be able to do that.
Do you want to stand up here maybe?
Or like to.
Yeah, but
Come and have a seat, yeah. Rob likes us to be nice and relaxed, so we'll perhaps all sit down, and I should do so too. So in terms of the audience, I mean, lots of practicing colleagues out there, trialists, and people that were engaged absolutely in this trial. Are there any questions from the audience? So we have a question here, Peter. Do we have the microphone? So we've one question here, and Paul. Yeah.
Peter McNaughton, Plymouth. Thank you for a very interesting trial. But my question is, did we really achieve permissive hypotension? Because the mean pressure, I think, in the intervention arm was 67, which surely that's what the current guidance is, to aim for a target pressure of 65. I think the challenging thing is when you set a target blood pressure is to actually achieve it.
Can we have this? I had a few extra slides on that first presentation addressing.
Just to bring that in, what I would say is that really what the aim of the study was to try and reduce the exposure to vasopressors, rather than actually necessarily going, we think a lower blood pressure is the key to this. It's actually about reducing that exposure. And as you saw from the baseline tables, the blood pressure, the map is coming into the study, when the clinician expected the patient to have at least another 6 hours of vasopressor, was around 70. So actually on the permissive hypertension arm, if you think a perfect adherence to that arm would be coming straight off vasopressors. And that patient would have had a mean arterial pressure of 70 for the trial. And actually, I think the idea that we tried to hit 66, it was a guide to try and reduce the exposure to vasopressors. So if everybody came in at 70, everybody came off, you would have seen a mean arterial pressure of 70 throughout the study. But actually, it wouldn't necessarily have meant that we didn't hit our aim, which was trying to reduce that exposure to vasopressors. There is, Francois, just have a look. There is some quite heavy evidence of how the practice did differ from the first hour of actually, it wasn't time to present it. The first hour of patients coming onto the study, it was quite clear in the permissive hypertension arm, the dose was reduced early and the blood pressure came down, and in the usual care arm, actually dose kept going up in the vasopressors, and the blood pressure was going up very early. You can see the separation, and there is a couple of
so yeah, maybe there's no need to, but that's the bottom line is because those map averages were calculated only for hours receiving vasopressors, if the intervention was followed, then vasopressors were discontinued, and the map was, gave a false impression of being elevated, where in fact the intervention had the desired effect. What the data that Paul is alluding to is these bar charts show you on the y-axis the hours of vasopressor therapy, on the left in absolute terms, on the right in relative terms, and you can see vasopressors were administered for longer periods. And the top part of each bar are hours where the MAP was above 75, and vasopressor dose rates were either stable or the dose even increased. And you can see that there were more occasions of these vasopressor infusions not being reduced as stipulated by the protocol in the usual care arm than in the intervention. And then as you go down in the bar charts are those modifications of vasopressor infusions that were appropriate according to protocol. And so on balance, the intervention increased the attention paid to reducing or discontinuing vasopressors. And another way of looking at this is looking at the hourly modifications to vasopressor dose rates and the corresponding change in MAP for the first 24 hours on trial. So very, very quickly, those numbers refer to hours after randomization. The two groups diverge pretty quickly and pretty significantly. But I guess that's that.
Kathy.
Can I just, so one of the things that convinced me, not only obviously the IP DMA that Francois had led, combining ovation and sepsis spam, was actually looking at some UK NHS data that we had from some of our previous trials, daily data. And really what the purpose of the trial was for me was about sort of what I might call curbing drift, if that makes sense. And what we had was daily data that showed that patients had been put on vasopressors early on in their sort of critical care stay. And then we just happened to have some trial data that showed daily what their kind of mean arterial pressure was, and that the fact that they were still on vasopressors. And the values were going from sort of 65 to 70 to 75 to 80 to 85, and they were still on vasopressors. And so it felt to me that the use of permissive hypertension here wasn't an absolute, but it was about trying to curb behavior. It was like a behavioral change intervention. What we really wanted to do was try and reduce the exposure to vasopressors. That was the aim of the trial. The permissive hypertension target was one of essentially trying to change that behavior by sort of curbing this drift, almost sort of getting patients off or not increasing doses sort of that appeared to be sort of what usual practice looked like from the data that we had.
Of course, we saw that was very important in the adrenal trial, getting off vasoconstrictors. Paul, I think you had a question.
question's sort of been addressed to an extent. I mean, I was going to raise a similar point, but I guess what I'm wondering now is... There we go, now you can hear me. What I'm wondering now is, it's all well and good to say we achieve separation of blood pressure, we achieve separation in vasopressor doses, but you know, I've always been writing on the chart MAP greater than or equal to 65, right? So I still don't know if I write MAP greater than or equal to 60, that's actually safe if people do it. And so I wonder what the thoughts were of the investigators on what the default target that gets prescribed should be, and whether that should actually change in response to these data. You know, like it's easy to say, well, you know, if I go around, I see the patient, the blood pressure's a little bit lower, I might be a bit more relaxed than I was before. But actually, the target, what's your take on that?
Well, so the targets that were prescribed in the context of this trial were MAPs, you know, with a range between 60 and 65. That's how it was prescribed, and then you saw the blood pressures and how it was delivered. But how it was written in the chart is 60 to 65. Now, I'll assume that when you write what you write in the medical charts, then you also obtain something that might be slightly different. You know, in terms of how to write the prescription, that's how it was written in the context of the trial, and for about 50% of all hours on vasopressors, the MAP values were between 60 and 65 in the intervention arm, if that provides some reassurance. But is there work to do to connect what's written in the chart with what's actually delivered to the patient? Definitely. There was a lot of, but I'd say that work has been needed for quite a while, probably.
And so my follow-up would be to say, well, surely to an extent, one of the things that stops the blood pressure actually going down to 60 in a substantial proportion of the patients is a feeling from the clinician at the bedside that actually for this particular patient in front of me right now, I don't think a MAP of 60 is okay, so I'm going to make the blood pressure just a little bit higher than that. Or it might not even be the doctor, it might be the nurse, right? Who's titrating the pressures up and down. So the difficulty I think that we might face here now is that disquiet might be removed by the results of this trial, and then if people try and implement it, then all of a sudden in clinical practice the MAP might end up being 60, and yet we don't know if that's safe or not.
I think what we found was there was very low duration when aiming for 60-65. What people tended to do was aim towards the top end of that range quite clearly to give themselves that little bit of breathing space around. And we saw very few measurements below 60. I think it was just over 3 hours per patient, or that were below 60 overall.
And so point well taken, and that may be the case. I think that on balance and historically, and you're right, this is very much a nurse-driven intervention, and it will continue to be so. So whatever you might want to do to your practice, you know, reading this, you better talk with the nurses. But the point, I think, is that collectively clinicians, physicians, and nurses are extremely concerned by the risk of hypotension, and I doubt that all of a sudden MAPs will fall to very low numbers. I think that we have not been very concerned by the risks posed by significant exposure to these potent drugs, and if anything, like there's never an upper alarm. You've said you've prescribed this as a greater or equal than, and that's interpreted as a threshold. You know, never go below, but as high as you want above, and that's safe. And we like it when the alarms don't go off, do we? So we're very much high up there to make sure that the alarms don't go off. So if anything, this gives us reason to pause and perhaps examine the possibility that it's not that safe way up there. And I doubt that we'll be in a territory where all of a sudden we'll have crazy hypotension.
So time is moving on, and we do have to progress this. I don't want to curtail this really important discussion, but we do 2 quick points perhaps from Anders and then Morten, and then I want to invite Paul on stage. So Anders, just briefly.
Yeah. So I think it's a very valid point, so this is obviously a complex intervention, and it's setting a new target, so 60 to 65, aiming at reducing exposure to vasopressor. That's the intervention. It was done in 65 UK ICUs with the culture that's there. If you will want to transfer the results to your own ICU, you should mirror that. Is my culture and my ICU the same as these 65 ICUs in the UK? If you can see that, I think the results are directly transferable. If not, there may be a problem, and you will have to discuss that locally, what to do about it. So I think the point is very valid.
Thanks, Anders. And just finally, Morten, did you have anything to add to
Morten,
that?
Copenhagen, Denmark. Thank you for a very nice trial and good presentation, and I also think that it has clinical implications for sure. So do you think, are the findings unique to patients beyond 65 years? Could this apply to patients age 52? Is it a general finding?
I think we need to find out.
We really used age to try and enrich the population to deliver a study that we thought there was a population that had most likely benefit from this. And actually, it's quite interesting looking at the IPDMA analysis of the interaction with age. Actually, it'd be better to go higher in younger adults. We don't know in that.
So we like a trial that's hypothesis generating as well.
Yep.
So fantastic. So one of the important things, both for the UK and the international community, is about how this trial was conducted, as we're about to hear, and may produce further discussion later on. And I'd like to invite Paul now, Paul Mounsey, who's the Director of Research at ICNARC, to come and talk a little bit about trial delivery. Thanks, Paul.
Thank you, Paul. Oh. And thank you to Rob and the organising committee for letting us help design this session. And this is something we really wanted to sort of highlight, and really how the UK community delivered this trial. It's something that Francois has very kindly avoided in his presentation. Okay. So we've got the title of how we did this. So there are a number of sort of people who took part, who were part of 65, but really where we want to focus is on the sites and really the delivery at the sites. And I think that we get to stand up here and talk to you and tell you the results, but actually, in reality, it's the 65 hospitals who delivered this trial who need the congratulations rather than us. Okay, this is skipping along quicker than I expected. Okay, so recruitment, as we can see, is difficult in trials. I'll just see if sorry, the animations don't work. So it's critical care, they're very complex trials. We can see on these 2 trials, so the calories trial is the top left, looking at what was the original target recruitment. Promise is the bottom right, so calories looking at route of nutrition, which had a 36-hour time window for recruitment. Promise looking at early goal-directed therapy, which had a more similar 6-hour time limit for recruitment as 65 did. The black lines, which are the top, are the targets, and the actual, which are the blue and the yellow lines in the respective studies. So as you can see, Promise is around, I don't like to say it, but about 18 months behind sort of where we hoped we would be. But then we got to, I'm hoping the animations do work here, the 65 trial, where if you could see it, the black line was the pre-trial estimate. If we went out to 2,600 patients from what we initially anticipated, we'd be about to finish recruitment next month. So it's great to be able to get up and present the results before we actually would have expected to finish recruitment. And you can see the UK community delivered the actual recruitment well above what we expected going into the study. And it was based on quite robust data on the case mix program audit, so we knew how many patients were out there. So why I'm having Anders' problem. I'm not sure why that is. Oh, okay. So why? So looking against between 65 and PROMISE and just doing a little bit of a comparison. They're both quite similar. They had 6-hour time frames to be able to get onto to recruit the patients from admission into the study. This is looking at day of the week of randomization. So Monday to Sunday, you can see 65 is pretty flat, slightly lower on a weekend, but you can understand that. PROMISE, very few patients actually recruited on the weekend. Very much, this is all around trying to embed the trial recruitment and procedures within your routine care. And when you look at, oh God, I'm not even touching it. When you look at time of day, which is even more stark, the PROMISE trial, very few patients recruited in the nighttime, and the 65 trial, pretty much you can't tell what is the night and what is the daytime. So working from the left, it's midnight, so it's midnight to midnight, x-axis, and it's pretty flat across, which really shows that patients were being recruited 24/7 from the sites by it didn't need the research nurses necessarily to be there at the bedside to recruit the patients. The whole clinical staff were involved, engaged in the study, and recruiting the patients throughout the nighttime and the daytime when they had other things to do, and research normally isn't top of their priority list. So this was fantastic to see. Oh. So, that's fine. So looking at how this was achieved. So things I want to pick up are really around the infrastructure that helped deliver the study and deliver all critical care studies within the UK NHS, and also how we helped, or how the study helped embedding the procedures into routine care. Okay, funding. So we might just skip the scoping slide between, that's fine. Oh no. Okay, so funding. We got funding through an efficient designs called in HRHA, which was really around also not just efficiently delivering a trial, but an efficient setup process, contracting process, etc. We had funding confirmed only 3 years ago. We got the funding for the 65 trial. We had the contract signed a month later. The grant start date was the start of March, and we projected to start recruitment September 2017. So it's a very efficient start to the... Okay, and looking at UK governance approvals, we've got a streamlined UK, apart from what I told Anders over breakfast this morning, we've got a streamlined UK approval process. We got the start of the grant, and was the 1st of March. We submitted for our Health Research Authority approvals sort of 7 days later, so we're ready to start, ready to get going. We had ethics approval within 6 weeks, and also the Health Research Authority approval, which coordinate the whole sort of approval process on the same day. So we're from start of the grant within sort of 6 weeks, 7 weeks, we're sort of ready to get going. So moving on to the important topic of sites. Oh. Okay, so we had a huge interest across the whole of the UK sites. We had expression of interest from 124 hospitals to take part. We needed 65. We needed 65 for the symmetry of the study. We had 65 blood pressure, 65 sites, and we really needed to make sure that we kept that symmetry. So we had 101 site feasibility questionnaires. This really allowed us to pick the best sites that we felt would really deliver the study. So we looked at past sort of quality of delivery on our studies and other studies across the UK sort of critical care research community. But we also looked at how enthusiastic people were, how well they filled out the forms, how enthusiastic the team, were the whole team bought into the study, or was the clinicians who weren't 100% sure permissive hypertension was the right way to go. So we took it as an opportunity, because we had 65 sites, it was a straightforward study, to try and also work with new sites who hadn't delivered a lot of research within the UK, within critical care before. We thought that was a really important sort of part of the study. And we had approximately half were non-university affiliated hospitals. So we selected, initiated, and activated, and Alvin, Francois, and a little bit of me went to all the sites to train them all within a few months, which was a lot of traveling, especially for Alvin and Francois. And this is what we got, 65 sites across England, Northern Ireland, and Wales. We're really embedding with the National Clinical Audit, and that's where the case mix program, the areas that the case mix program covers, the only reason Scotland weren't involved. And the site setup. So the grey bars is what we expected. We actually got set up, started 2 months earlier, and the sites were very keen to get going, and we had 17 sites open in July when we were looking to start recruitment in September 2017. It was a fantastic sort of build-up, sites ready, keen to get cracking. And we hit our 65 sites pretty soon, or around the 65 sites pretty soon. And the top 10 recruiters. Actually, I had a quick look at this yesterday, whether the feeling was the smaller DGHs often are the better recruiters. It's not all about teaching hospitals delivering our research in the UK. And if you just look at the top 10 recruiters there, they're not necessarily the biggest, most familiar names that you'll see, but they delivered brilliantly on the study. These were the sites who really did embed the study. They got the whole teams bought into it, embedded the study throughout 24/7. And just picking up, we've got Queen Elizabeth Woolwich there, who are the top recruiters. It does say they're university affiliated, but it was actually their first, if it goes back one, which it's been doing. Oh, not that far. Thank you. And they actually got a highlight in the by the NIHR on their recruitment onto 65. This was their first study they delivered, and really was about how they managed to get their whole team involved in delivery. And it was a fantastic story to sort of see. And this is only possible because of these are slides from Paul. Paul chairs the National Specialty Group for the Clinical Research Network, does a fantastic job. The National Clinical Research Network is a key part of delivery at sites. So when we put in a grant application to the NHR, we tell them how much it'll cost to run centrally. We also tell them how much we need to give hospitals. But also, we tell them how much the hospitals need to actually have for all these aspects to identify, recruit, consent patients. And that comes through local funding through the networks. And it's a fantastic setup that we know research nurses are already in place. They're delivering a portfolio of studies, and we can just tap into the research nurses to deliver that. We don't need to set it up with completely new research nurses, et cetera, for new studies. And they're brilliantly trained, and they will deliver the studies. They know the area fantastically well. When I started 10 years ago, critical care was reasonably early-ish in that journey, and the research nurses are still here and delivering and now really experienced. And that was just to show there are clinical research nurses across 31 sort of clinical specialties. And I say Paul leads the critical care aspect, and it's a fantastic resource. This is a bit of self-congratulations from the the clinical trials unit. And we think it's important. You've got an experienced specialized unit in critical care research. We had a really focused trial management group. We had a couple of clinicians, we had a research nurse who wrote all the transcripts. So Julie at Poole wrote all the transcripts for the research nurses for the deferred consenting model. We had 2 patients on our trial management group who put in fantastic support, and it was really, really important. Alvin did a wonderful job as trial manager, which is a huge role in these sort of studies. Francois was with us for a year with the international collaboration, and we're very open to it. And we got a large network of hospitals through our case mix program, and we could data link and routinely link to the case program, which is a fantastic resource to have. The 65 promotion messaging was key. And using these are just aspects. 65 logo is fantastic. Kathy will take the credit for designing it. Using a speed sign for sort of you should stop at 65 was a very useful and very good thing. And people could make. These are just examples of what the research nurses were trying to do to try and embed and to just raise the profile of 65. It worked fantastically well. The randomization and intervention delivery was streamlined and straightforward. We had a simple telephone randomization system. We gave the option of online, but it was never used. I think we had 2 or 3 patients recruited online. Minimal training was needed. An intervention, it was targeting a single parameter could be delivered by clinical staff, and we used the 65 prompts to remind about the intervention. The relevant consent model. So you're not rushing people into consent. So the importance of actually informed consent deferred is vitally important. It led to a slightly higher rate of non-consent, but it actually mimics, this is work in pediatrics, intensive care that we've done, on the team in Liverpool have done, and it mimics very well that this is a really acceptable way, not causing distress to family members and patients at the time. And the last thing I want to say is really around the data-enabled aspect. It really takes the pressure off research nurses to filling in too many case report forms, too much data at the bedside, and linking to routine data with civil registrations, but also case mix program was absolutely key, and we focused data collection on blood pressures and vasopressors. And just again say thank you. Thanks all.
Thanks, Paul. That's great.
Bit long.
So I'm going to stay seated at this point because we now want to invite the panel along. But before we do that, I just wanted to ask Matt Devine if there's anything pertinent that has come up on Twitter through the hashtag. There's a big international audience out there that you might want to raise at this point.
So Twitter has exploded this morning. A few themes have emerged, which I'll just summarise. Does this have unintended consequences? Will this make us less likely perhaps to admit patients to ICU who have borderline mean arterial pressures at the point of referral?
So we'll perhaps bring that up in the discussion. If you could just pose that question and think about that, hold that. And the second?
And the second thing is really around methodology and statistics. Given in this study there wasn't a statistical significance, but perhaps a signal to a change in mortality, do we need to pay maybe less emphasis on p-values and look more at clinical significance?
Okay, so I think those might be two good starting points to introduce the panel, actually. So we've got a list of people down here who are real experts across the world, and I just wondered if we could go round and spend sort of 15 seconds saying who you are and what you think you bring to this. We've invited you here for a very good reason. Terry, do you want to start with you?
Certainly. Hi, I'm Terry Huff. I'm from the University of Washington in Seattle in the United States. It's certainly a pleasure to be here. Thank you.
Thank you, Terry, and you're very welcome. Kathy?
I'm Kathy Rowan. I'm director of the ICNARC Clinical Trials Unit. I've got absolutely no idea why I'm here.
Accountability, Kev.
Yeah.
So Anders, please.
Yeah. Anders Perner, Copenhagen intensivist and trialist there.
Thank you. Andrew at the end.
My name is Andrew Althouse. I'm a clinical trial statistician from the University of Pittsburgh in the United States.
That's great, and we've already met Paul and Francois. So should we take the clinical question first? Perhaps Francois and then Terry and Anders, around this whole question of bars to admission to ICU, that perhaps this notion of a patient that is a bit borderline in terms of their blood pressure control, that there might be an increased barrier for admission as a result of this trial, which may prevent other important interventions, observations and gestalt that we offer in critical care. Francois.
I mean, who knows, right? Are patients mostly admitted to ICU because we want to administer vasopressors, and let's say we are worried that they might be in shock and choose not to administer vasopressors, would we feel they need ICU less? I'm not sure. It's a great question. It's something maybe to study in the aftermath of this publication. And then there are a number of other interventions trying to get us to recognize, early warning scores, and that's still happening. So I'm not sure. And then, yeah, I guess I would say I'm not sure. It's an interesting question to ask.
Okay, well, thanks for addressing it. Terry, have you any thoughts from a West Coast of America perspective?
Yeah, no, I think that's a very important concept to bring up. I think when we're generalizing our trial results, we need to remind ourselves, how was this done within the setting of the trial? And this was not a trial about, can patients with lower blood pressures be safely managed on the ward and out of the ICU? Every patient in the study was indeed managed in the ICU setting. So I think that we need to be careful, right, that it's not extended beyond what was done. And in fact, you could even say that perhaps these lower blood pressure targets were safe because they were so carefully monitored within the ICU setting. We're dealing with this acutely right now in the United States. We're doing a trial called Clovers through the PEDAL network that's looking at sort of more vasopressors early or more fluids early for patients with sepsis and septic shock. And this has been a big concerning point, that the patients who are randomized to the group that's not getting early vasopressors, that they'd more likely go to the ward since they don't have the indication for being in the ICU. And at my hospital, we've pushed really hard to say these patients are all the same at the time of randomization, and whether or not they start on a little bit of norepinephrine, they should be carefully monitored in the ICU.
Thank you, Terry. That's a nice perspective. Anders, from a continental European perspective.
I'm not sure that, I think the opposite may be more challenging, because we come from a culture where we're used to teach and pray that hypotension is dangerous. So the culture among our colleagues and nurses is that the pressure has to be higher, and I think that's why we almost always in trials on vasopressors see higher pressures measured, delivered than what the target is. So that's our culture. So I think actually it will be more difficult to adhere to permissive hypotension, to change the culture from being hypotension is dangerous, let's be safe and put the patient above the target.
Okay, thank you. And I guess and it kind of alludes to Paul's point as well, is what's the trial told us about implementation of this evidence? So the NIHR are very keen after public investment of making a difference. So we think we've probably learned things from this trial. But what should implementation look like in our centres? Do we have key information from the trial that would allow us to implement safely? Perhaps, Kathy, can I ask you that question actually? Implementation of your trial results.
The implementation of the trial results?
Yeah, what have you learned in the trial that's going to be key for us to consider when we consider implementing the results of this trial?
Okay, so the first thing I would say is I sit with Anders on the notion that I think pooling these data with the individual patient data from the other trials, so adding in another sort of 800-900 patients will be important insight. I think that if I talk about a perspective of me being a patient, I'm not quite 65, but it feels like it's getting reasonably closer every year. I think that I wouldn't want to be left drifting on vasopressors. I think one of the results for me that's quite interesting, and I know it's a subgroup analysis and pre-hoc into the IPDMA, is this one on chronic hypertension. I'm not a clinician, as everybody knows, but as I understand it, in that group, the idea is to shoot for higher mean arterial pressure because that's sort of their usual normo sort of. So I think that sort of makes me feel a little bit more comfortable. And so I personally, when we looked at the kind of the data, what you realize is as people are being given these vasopressor drugs, it's not an absolute, it shoots above, 65, but you're aiming between 60 and 65, and you could see that happening. The adherence in this study was fantastic. I mean, the sites, when the patient was randomized to the 60 to 65. So for me, I think the implementation is certainly one of understanding more from the data, both pooled with an IPDMA, and I think one of the nice things about, you set up a trial, you've got to bear in mind, we write that statistical analysis plan almost 3 or 4 years ago, and that's what we forget when we publish a trial. We go, that wasn't very clever, they didn't think about X, Y, and Z. You've got to think about when those sort of thoughts were sort of being put together, and then I think what happens is you get important post hoc insights. And so there's a part of me that I agree that dichotomania is not the way to go. On balance, I would like to be managed and brought off vasopressors when sort of my map is between sort of 60 and 65, if that makes sense. I hear what Paul's saying about 60, and what was interesting was how few of the hours, how in both arms that patients drop below 60. So that's my takeaway. I want to understand more. which is always the case for me in trials, is always left with begging questions. But if you really want me to make a patient decision now, I would have sort of 65 on my chest, on my forehead or whatever.
So there's just, I mean, there's a methodology question here about dichotomous outcomes, but just before we get to that point, the notion of implementing trial information.
So I think the sites are the people to tell you how it should be implemented, because they did it.
But methodologically, this is a complex intervention. We wanted an efficient trial, but within our culture in the UK, did you consider doing things like process evaluations to really understand? Sorry.
So what we did do is every time so we defined sort of non-adherence as 3 hours where the MAC was above 65, and that we didn't see a reduction in vasopressor dose or a discontinuation of vasopressor. And what we did do is we followed up every single, I think, occurrence of this with the sites and found out exactly what happened. And there's some quite clear where the issues were on any sort of non-adherence, and they were very much focused. The main reasons were sort of staff logistical issues, really, rather than actually necessarily specifically that patient they felt should be pushed to the higher blood pressure. And it was things such as maybe the nurse overnight didn't know the patient was on the study, even though we put stickers everywhere or desk people too. They didn't necessarily know that patient was meant to be managed to 60, 65, but it was overnight. Maybe it was a nurse who wasn't familiar with the study. But also maybe they had other clinical priorities, such as there was physio, the patient was, or there were other clinical priorities that meant the vasopressors weren't necessarily their first priority, and managing the blood pressure too wasn't the first priority. And I imagine that, if you're bringing into usual care, would have just gone further and further rather than sort of necessarily trying to actively titrate. There were clinical queries that came up, so things like worry about low urine output, as people can imagine, it did come up. There's a number of times. I think that was the main concern with the potential renal concerns, but as we saw, the results didn't sort of really back that up. So I think we do have quite a lot of data on sort of potential protocol adherence, which could feed into how that could be implemented.
But it is also important to say the adherence was absolutely fantastic. I mean, I can't remember, is it something like 6% of the total hours on vasopressors, i.e. where people could have not adhered, there was hours of non-adherent, you know what I mean, sort of type thing. So I think when you come to go along with the process evaluation, it was funded, as you say, Paul, in the efficient design. So the idea of it was, could you clinically embed, use data linkage, and drive a trial rapidly to what we expected a recruitment period to be, and as you can see, sort of shot that down because of that engagement. But I actually think the information will come from the sites in terms of if those other sites not in the trial, the sites in the trial, that implementation. And some of the feedback is around the reinforcement, the simplicity. We laughed about, we wanted 65 sites recruiting for 65 weeks to a blood pressure target of 65, in 65 or all,
65,000 pounds.
There was we didn't do it for 65,000 pounds, not quite, but 65 million would have been nice. So there was a sort of a symmetry and a kind of prompting and that kind of type stuff, but the sites are the experts.
Okay, thank you. And we'll perhaps come on to that with some more questions from the audience shortly. I'd just like to loop in Andrew at the end. By the way, I've got Andrew's Twitter feed up here, so I would strongly recommend you following Andrew, AD Althouse PhD. Andrew's prolific on Twitter with his statistical knowledge, and I wondered if we could develop this discussion further, the point that Anders made around dichotomous trials and hypothesis testing.
Yeah, so the latter question that came from Twitter, I think very nicely stemmed out of Anders' presentation, and he did a really, really nice job sort of addressing this issue about dichotomania. And I love that graphic that you put up showing the sort of 3% in the middle with like the darkest shade and then kind of slightly lighter shades as you move further out, because the challenge that we have is that 3 is not for certain the effect size. It's our best estimate of the effect size given the data that we have, and become sort of progressively less confident as you get away from that 3. So it could be as high as perhaps a reduction of 7% in mortality, or it could be perhaps a slight harm. One point that Anders made, which I thought was really keen, is that there's sort of an interest in doing less, perhaps. And you might wonder whether the bar for a trial is a little bit different when you're talking about approving a new medication or approving a new procedure versus this, which is sort of like a de-escalation or a do less type trial. And whether really this is a bit more of a non-inferiority question than a superiority question. And we don't have time, unfortunately, to go into a full discussion of the merits of non-inferiority designs and their challenges relative to superiority designs. But I do think it's fair in the interpretation stage to look at the data almost through a non-inferiority lens as much as through a superiority lens and ask yourself, did the permissive hypotension arm really need to conclusively prove itself as much better to warrant adoption? Or is it the sort of thing that maybe if the balance of the data suggests that it's probably better and probably not harmful at the very least, then maybe this is something that at the very least probably can be safely done and explored without increasing harm. There is one other point that Anders touched on, which I would like to expand on even more, was the supporting sort of sensitivity analysis and subgroup analysis. And if there's one thing I really, really hope I can do at this meeting, if I don't get anything else out of this meeting, I'll have done some good, is that there seems to be a belief that in clinical trials there's no need to do any sort of variable adjustment. There's no need for a regression analysis. And it is technically true that there is no need for a regression analysis and to have a valid randomized trial. But if you specify some variables beforehand that you know are likely to have a strong relationship with the outcome, that can improve the efficiency of the trial, that can improve the accuracy of the effect size estimate and the confidence interval. And I thought it was very interesting in the primary results to see that, and this is the sort of thing that drives statisticians nuts when we try to have to explain this, that the unadjusted result just barely wasn't significant, sort of in favor of the therapy. But the adjusted result was. And a lot of times people ask me, what am I supposed to make of that? And I say, well, the truth is, if the variables that you've chosen to adjust for are well justified and strongly associated with outcome, the adjusted result is probably the more accurate result. And if you're asking me which one of those two to believe, it's the adjusted result. Where that gets complicated is people worry that you're sitting there fishing for which variables you should adjust for until you get the result you like. So if there's something you can take away from this, I think moving forward in terms of statistical analysis plans and trial interpretation, I think the key is that when you have the situation where you might want to adjust for some variables, if you're able to specify them ahead of time, that way you sort of have confidence that the investigators didn't sit there and say, all right, what if we adjust for age? I don't know, take age back out. What if we adjust for this, take that back out? But the truth is the adjusted result is probably the result that's more trustworthy in this setting.
Thank you very much, Andrew. I mean, it's interesting about the non-inferiority design and whether the data would support what size of a trial you'd have needed to have very tight
yes, I mean, it certainly wasn't a non-inferiority design, and we need to be really, really careful in how we kind of articulate the findings. It was a superiority trial.
Any things you'd like to come back?
Well, I just think, I agree with Andrew, so that's an easy one to come back on. And I think, one of the things that struck me, even randomizing, 2,600 patients, not a good measure of frailty. I accept activities of daily living, etc. But the usual care patients actually were slightly frailer, if that makes sense. And that was and all the adjustment we did was it the other way around? Francois was telling me, I'm sorry. Sorry, you're absolutely right. The permissive hypertension were frailer. That's right, sorry, forgive me, I am getting that the wrong way around. So it's the thing that sort of says to me, you get imbalance even in quite a large number, okay? And then I agree entirely that, pre-specifying and publishing a statistical analysis plan, which we adhered to absolutely. We then got asked, as you often do, for some of the analyses maybe. One of the other things that moves on is statistical methodology in trials. And, there are people who argue for relative risks against odds ratios and all of that kind of type stuff. And you want to please all the people, particularly when they come from JAMA. It's amazing. You want to please them. And so, and I think labeling things as pre-hoc and post-hoc is really important. But, I think we did the job that we did pre-specified.
Does Howard want to come back on that one? I can't see him.
Sorry, Howard.
Okay. So I think we've got a few more minutes just to tidy up. Are there any further questions now we've developed a discussion from the audience? Please, if you could get a microphone to the front. Thank you.
Thank you. I'm Amar Gebbers from Amsterdam. I have a problem with the basic assumption of what blood pressure we should aim for, because you give a figure, and I was trying to teach my fellows that they should aim for the blood pressure that is enough. And just by putting down a figure, it might be a very good help, as Kathy pointed out, is to make an incentive that people use less catecholamines or inotropes. So I think that is a very good goal, but it's a little bit of an unsophisticated goal, because what we want is that people discover in an individual patient what is enough as a blood pressure. The same holds true for cardiac output or whatever. I'm not interested in what is the cardiac output. I'm only interested to know whether it is enough. You have a size of your coat that is probably enough for you, but I guess that it's not enough for me.
Okay, so Francois, do you want to take that?
Fair enough. Great point. I guess what you bring up is, surrogate endpoints, and to what endpoint should we be resuscitating? I'm on a daily basis in the ICU fairly certain that whatever we did for a patient was not great when the patient dies, and was probably good enough when the patient survives. The problem is that it's difficult to know beforehand, and I would, and I feel I'm the same. When I have that clinician hat, I have to make decisions based on what we have. The issue, and Paul Young speaks about this quite well, the issue is I would challenge the assertion that we can currently rely on what most people propose as endpoints of perfusion or function, or I would challenge the assertion that urine output is a good marker of kidney health. I don't think creatinine clearance is a great marker of kidney health. ACE inhibitors in diabetic nephropathy reduces clearance and it improves kidney health. And in the same way, I would challenge the assertion that lactates are perfect. They are, lactate levels are modified by catecholamine stimulation. And so I think it's easy to fall into this vicious circle where lactates are high, we feel we're not doing enough, we increase the doses of whatever we're giving. The direct effect of this is to increase lactate, and then patient dies, and we say died in spite of best care, where in fact our best care might have played a role in this. So completely agree with you in principle. The devil is in the details, and it's that I don't have great ways of directly measuring flow or function or predicting what will happen. If I felt confident we do have those tools, they would have been incorporated in the trial, I guess.
Okay, we've got 3 microphones. Oh, sorry, Terry, did you want to come back on that?
Just a very quick comment. I agree, but at the same time, I think there is a risk of giving too much power to the clinician at the bedside to say, I know what's good enough, or I know what's best. I would have guessed that patients with higher blood pressure at baseline would do better with higher blood pressure here, and yet these study results show the opposite. So our gut sense at the bedside is often wrong, and maybe we shouldn't have too much power.
But that did not say best, I said enough.
Right, but enough. If your baseline map is 80, then maybe we would say perhaps 80 should be enough, when that's probably the wrong answer.
Okay, we've got 3 more microphones out to draw us to a close. I'd like to take the first question here. Thank you. Are you working?
Hello?
Not so well, actually. Apologise.
Hi, try again.
So shall I try again? Shall we get you a new microphone, and then I'll take another question first? Because we really want to hear you. Okay, right towards the back. I can't quite see. Oh, is it Steve? Yep.
Hi.
Is this working? Yeah. Just thinking about the adverse effects, were you surprised at the lack of difference in the two groups with adverse effects? Often one of the reasons why we're reluctant to give vasopressors, obviously, is the risk of adverse effects. There didn't seem to be any major differences between the two groups.
I was happy we didn't see huge differences. Paul and Alvin and the entire team put a lot of energy in discussions with sites. This was not a blinded trial, so we were concerned that there might have been a risk given our a priori concerns that low blood pressure might be harmful, that there would be differential reporting. And I guess looking at those numbers, we were very happy that there didn't seem to be differential reporting. If we were surprised, I don't know.
But I think what we didn't see was acute effects from vasopressors causing adverse events. And I think maybe actually when you look at the trend over time, it's slightly later when there's a slight mortality change. It wasn't these, I think, acute adverse effects that were causing the mortality changes, differences.
Okay. Can we take a question here finally?
Okay.
Thank you.
My name is Maria. I work as an intensivist and trialist in Stockholm. And I'm interested in how the blood pressure was measured in this trial.
It was measured as it's measured every day in routine care. This was very much a pragmatic trial. So in most instances, just like it happens most every day, it was measured via an invasive arterial catheter. And as it usually happens, it was mostly measured via arterial catheters rather than a catheter somewhere else. But if as it would happen, I guess, in Stockholm, just like it would happen where I work, if you lose all your catheters and you're still running vasopressors, then they use the blood pressure value they had in both arms. This was done very pragmatically.
Thank you, Francois. I'm afraid time's getting very short. We've got one final question, I think.
Hello, Peter McQuillan from Portsmouth. I want to follow up on that last question. Recognising that RCTs are beneficial because the errors occur in both arms, hopefully, to the same degree. If we're measuring blood pressure, I'm just worried about the discipline of measuring blood pressure. And what is a blood pressure? Yes, it's arterial. Is it radial, brachial, femoral? They're different, and they change from time to time. And therefore, the baseline variance of our measurement is quite noisy. And if we're trying to pick a difference in blood pressure from a very noisy signal, then it's going to be quite difficult. So we may therefore have underestimated the error so involved and hence underpowered our trial, as it were.
So there are additional interesting research questions to pose for sure, and point well taken. That uncertainty about what the blood pressure exists and has existed forever, and every day we have discordances between art line, cuff, femoral line, and that happened before and it still happens.
And current clinical care is delivered to those noisy, perhaps ill-measured, perhaps measured in different, so the trial, if you like, tried to parody that, if that makes sense, or that's the pragmatic sort of approach. I think, there's a lot of work around explanatory trials and measurements and measurement error and that kind of type stuff that's all really important too. But this is the noisy sort of rough and ready mean arterial pressures that you guys use day in and day out to deliver clinical care.
But perhaps the next time we have a bit more discipline about what it actually is and where we measure it and make sure that the transducer stays in the right place at the heart, for example, rather than patients moving up and down and all that.
Thanks, Peter. We'll have to call it to a conclusion now. So thank you as trial centres. Thank you for the investigators, the editorial, the comments, the discussion. It's been great. One thing I've learned from this is that we're in great shape in critical care in the UK in terms of reaching out to our populations. I think the recruitment data across the 24-hour cycle is fabulous, and the NHR are going to be delighted that we are reaching our patients with research. So thank you very much.